On Thursday, June the 13th, the health ministers of the G8 nations met in London to discuss various matters about global health. Amongst these was the rise of antibiotic-resistant bacteria. I'm Geoffrey Carr, Science Editor of The Economist, and I have with me Dame Sally Davies, who is the UK Government's Chief Medical Officer. Dame Sally, could you explain what you perceive the problem to be and why you think it's so dangerous?
Well, we are surrounded by organisms. Actually, about 2.5 kilos of our body weight are microbes. And increasingly, they're becoming resistant to routine antibiotics and even to rather more special ones. If you take the example of gonorrhea, we have only one drug left. It's a more expensive drug, and there's now resistance to that. Meanwhile, we have had no new antibiotic classes since the late 80s. We've just had modifications, and pharma have been steadily withdrawing because of market failure from the antibiotic market, both the research and the development. So what I see coming together is a catastrophic risk of increased prevalence of antimicrobial resistance, and all the surveillance demonstrates that that has started to take off dramatically over the last 5 years, with no new ways of treating. And once a new antibiotic has been discovered, and I understand the science is really very difficult to find new ones, it takes a minimum of 10 to 20 years to get an antibiotic through into the market and into patients. So if we don't start now, I predict a major problem.
Catastrophic is a very strong word to use. I can see that there is a problem here, but I've been aware of people talking about the problem of antibiotic resistance almost since I was sentient, since I was a schoolboy back in the 1970s. And they were talking then, and they still talk now, about the idea not just that you might have a more serious problem in hospitals, which I entirely accept, but that you might have some serious epidemic which couldn't be treated with antibiotics. And I find that somewhat implausible. First of all, it hasn't happened yet, except perhaps in the case of tuberculosis. But secondly, the nature of bacterial infection suggests that you're unlikely to see one of these things. Do you not feel that perhaps the problem is being slightly over-egged outside the context of people who are already in fairly serious medical trouble in hospitals?
I'm not given to overstatement. I, as a doctor, I'm a haematologist, saw in my clinical practice antimicrobial resistance, and we always had drugs to overcome it. But when I wrote my annual report, I did it in a new way. I brought in all the experts and got them to write individual chapters and to give me the up-to-date evidence. I was quite shocked that in the 5-6 years since I stopped clinical practice, how antimicrobial resistance had increased dramatically. You mentioned TB, and I think that's a very good example, particularly in the former Russian Federation, but we have drug-resistant TB. We had in 2011, the last cases I've got, 81 cases in this country, difficult to treat, resistant to 2 or more antibiotics, extreme drug resistance. We had 6 cases then. They are extraordinarily difficult to treat. Many of them die. That's taking us back to a picture of TB that I saw when I was a house doctor in that first year at medical school back in the early 70s, where I sat by people's beds and they died of TB.
Antibiotics are not the way that epidemics of bacterial disease are broken. They're broken by public health measures. So where is this epidemic going to come from?
Well, what you're thinking about and talking about at the moment is human health.
Yes.
Let me put this in the context of One Health. So animals are part of the reservoir of this, and antibiotics are dramatically overused in animals. They're used for growth promotion, as you probably know, also in fish farming. So 70 to 80% of antibiotics used in the States is in the animal world in agriculture rather than in the human world. And we do know there's a direct link between, for instance, salmonella with antimicrobial resistance in fowl, in chickens, and humans acquiring it. We have evidence that I've seen of bacteria in the water in both Japan and the Arctic, which have antimicrobial resistance. So because of these other reservoirs and other uses of antibiotics, we're developing antibiotic resistance that is getting into the whole bacterial kingdom, and that therefore, if you develop routine infections in the community, it is increasingly likely that they will be with bugs that have got resistance, and so they won't be treatable in routine cases. I agree that this is not yet happening in the community except in rare cases, but it is already happening, and we're not developing the new antibiotics.
So what would your solution be? Obviously one could use antibiotics more efficiently, although I would say in the defence of people who use them in animal husbandry that they're very useful there. But are there other actions that can be taken?
Well, I am told by all the experts that we should no longer countenance antibiotics in animals for growth promotion, that they should be used, as in humans, for treatment, and they should be used much more carefully. And you can almost eliminate them from fish farming by using vaccination. The Norwegians have dropped their antibiotic use dramatically. Indeed, we in Britain, through vaccination of fishes, have reduced our use of antibiotics in fish dramatically. So the experts tell me we should be using it for infection in the animal kingdom.
Your own profession has come in for some criticism, or members of your own profession, for over-prescribing antibiotics. It's prescribing them for what look like viral infections, for which they're obviously useless. Almost using them as a placebo to make the patient go away. Is there any way that doctors could be induced to behave more sensibly?
Well, I think this is an issue between doctors and patients that we need to educate the public that many infections, particularly in the community, don't need antibiotics and are self-resolving, particularly viral ones, and to make sure that the right antibiotics are used. But yes, I'm sure on occasions I have prescribed antibiotics when they were not ideally indicated. So there's therefore a need for better rapid diagnostics, because if you had a rapid diagnostic and you could say it is a bacteria and it needs this, we would not have the prescription for viruses where it will not be helpful. So there's a market need for new rapid diagnostics that are affordable.
There's also, as you observed, a need, or at least a desire for new antibiotics. How would you go about stimulating that need? The reason that antibiotics and also vaccines are not much made by drug companies is that they're one shot. Limited use, they don't have a huge amount of profit in them. How would you, if you were in charge of policy on this, how would you encourage drug companies to discover, develop and disperse new antibiotics?
Well, with the World Health Organization, we've started a discussion with drug companies on this. If you look at the example in Europe of the Innovative Medicines Initiative, that's a private patient partnership. It's putting a lot of money into antibiotic research and development. I understand that the basic science is quite complex and difficult at this stage, though genomics may be opening it up. So I think we need to look at mechanisms like that, maybe advanced purchasing mechanisms, but we've started to open that debate up.
Dame Sally, thank you very much.
Thank you.